Right. Have you seen a case of pregnancy complicating hypertension in your UG days in OG posting?
Yes, sir.
Okay. What are the features of pregnancy-induced hypertension?
and vitals, BP, saturation, pulse rate, and respiratory rate we have to examine. And we have to examine the patient and sitting in left lateral position, sitting or in left lateral position. We have to document site and in which limb we are measuring. We have to document it, and we have to note, examine the jugular venous pulse, and we have to examine for pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema or facial puffiness or sacral edema. And we have to note the weight and height of the patient, and BMI has to be recorded, and IV access of the patient has to be uh, mentioned, and palpation of sinus process is must, and breast examination is must for the patient. And pertaining to the airways, we have to examine for the mouth opening, and malampathy grading have to be noted, and thyromental distance, and TM joint mobility, neck movements, and bilateral nasal have to be seen. And regarding the systemic examination, CVS examination, we have to examine for S1, S2, and any murmurs and apex beat have to be heard. And regarding the respiratory system, we have to examine the upper airway, and we have to examine the trachea whether in central position, and we have to examine the chest movements and bilateral air entry is plus or not, and we have to examine for have to be noted. And regarding CNS, we have to examine the we have to mention mental functions and examination, and sensory and motor system examination, and also any cerebellar dysfunction has to be ruled out, and any meningeal irritation symptoms have to be ruled out. And pertaining to obstetric examination, we have to examine the fetal heart rate and the fundal height of the patient corresponding to the age of gestation, and the lie of the fetus have to be examined whether in longitudinal lie, and the presentation of the fetus in cephalic or not, and diagnosis is a summary. A 25-year-old primigravida who is 34 weeks of gestation, hypertension for 34 weeks, and who complains of severe headache, pedal edema, blurring of vision, BP of 210/120, and diagnosis is severe preeclampsia with features of hypertension crisis. And I will initially rule out with the investigations, baseline investigations have to be done, the CBC of the patient, including the platelet count, serum urea and creatinine have to be examined, and RFT and LFT have to be done, and or any end organ damage have to be done. Continuous maternal and BP monitoring to be done, which to be done every hourly, and urine output you have to document every hourly, and ultrasound monitoring of the fetus, heart rate, and be noted. Then regarding antihypertension, antihypertensives, to maintain the target BP of 140/90, or at least to decrease the mean arterial pressure by 15 to 25% of the baseline. And most commonly, IV drugs on the day of AC inhibitors and thiazides should be stopped on the day of surgery. And IV labetalol, you have to give 10 to 20 mg IV bolus, followed by 20 to 80 mg every 20 minutes. We can give at maximum of 300 mg, or as a IV labetalol infusion, 0.8 to 1 microgram per minute, or IV hydrolysine 5 to 10 mg, maximum of 20 mg as slow IV bolus. If still uncontrolled, we can give NTG infusions or sodium nitroprazide as per titrated as per BP. For anticonvulsant therapy, we have to start her on max self regimen. We have to start as IV bolus 4 gram over 10 minutes, followed by 1 gram per hour infusion for 24 hours, or 0.5 gram per hour if oliguric. Monitoring of urine output is must in this case. We have to titrate as per the urine output. We have to give this max self regimen 24 hours post delivery, or till the last episode of eclampsia, whichever is later. We have to monitor side by for the serum magnesium levels to rule out any by clinical levels or biochemical levels. Clinical levels by ruling out patellar reflex and any blurred vision. We have to see, we have to maintain therapeutic range of magnesium in the range of 2 to 4 millimoles per liter, and if it is more than 5 millimoles per liter, there is a loss of patellar reflexes and blurred vision, and if it is more than 7 millimoles per liter, respiratory depression is common, and if magnesium is more than 10 millimoles per liter, there is a risk of cardiorespiratory arrest. And we have to maintain the target BP, and if it is achieved, IV antihypertension, we have to continue it, and continuous fetal heart rate monitoring and CTG is cardiotochogram monitoring is must, and both maternal and fetal surveillance should continue throughout the delivery. And delivery is the choice for this patient, and the choice of anesthesia is, I used to prefer for regional anesthesia as a single shot spinal preferred over epidural if there are no coagulation abnormalities, except if there is a contraindication for spinal anesthesia like low platelets and coagulopathy. The safe range of platelets is more than equal to 75,000, and contraindications for giving spinal is low platelets, coagulopathy, and if the patient is post-ictal status with abundant level of consciousness with recurrent seizures, or a refusal to regional anesthesia, or there is a pulmonary edema associated with hypoxia, or there is a pressure response to laryngoscopy. Have to proceed to GA.
You completed?
But 0.5 that rate on patient as a GA, we have to consider them as a full stomach, and rapid sequence induction is must, and all difficult airway cards should be made available, and we have to attenuate the pressure response to laryngoscopy since it may lead to intracerebral bleed, and stroke is most common. And we are to attenuate the pressure response to laryngoscopy, we can give the magnesium as 0.5 to 1 gram IV bolus, or labetalol 25 to 50 mg bolus, or parenteral opioids like alfentanil is very potent, which can be given as 1 to 2 mg IV bolus, and emergency drugs like Lasix to be given if pulmonary edema is suspected. And we have to continue Maxwell regimen throughout, and invasive BP monitoring arterial lines is must, and neuromuscular monitoring is must, since magnesium sulfate will interfere, will potentiate the non-depolarizing muscle relaxant. So neuromuscular monitoring is must during general anesthesia, and we can give utrotonics, but we have to avoid ergot alkaloids like ergometin and synthometin since it may aggravate the BP. We can use syntocinon for it. And regarding the fluid therapy, restricted fluid therapy, we have to prefer co-loading over the preloading, since it since already the patient is in a contracted blood volume, and further fluid management can be detrimental to the patient. And regarding uh, uh, even magnesium sulfate also uh, potentiates uterine atony, so it can lead to atonic pph in the post-operative also. So we have to monitor for pph and get ready for all the drugs like carboprost and all, and we have to alert blood bank regarding it, and all the uh, blood blood products should be reserved, and emergency transfusion indicated. And proper teamwork and proper communication is necessary, and risk of placenta transfer of drugs is increased, mostly during general anesthesia, due to impaired drug metabolism and increased risk of neonatal and also most common due to and techniques of generation practice 43 millimoles of sodium citrate, which is 40 to 60 minutes before the procedure, and uh, H2 blocker like ranitidine 40 minutes before surgery, and IV metoclopramide, which is 30 to 60 minutes before surgery, and uh, left uterine displacement or tilt is must. We can keep a wedge to prevent supine hypotension syndrome, and we have to pre-oxygenate adequately, and labetalol, IV labetalol is must, and it also attenuates the stress response to surgery and also acts an antihypertensive, and all difficult airway cart available for the rapid sequence induction, and we have to maintain hemodynamic stability, and we can induce with thiopentone or propofol, and fentanyl we can give it as 2 mics per kg, and succinylcholine 1 mics per kg. We can use a smaller size ET tube, since in pregnancy induced hypertension there will be airway edema, so we have to prefer a smaller size ET tube, and we can put NG tube, nasogastric tube after the intubation, and we can maintain the general anesthesia with volatiles like sevoflurane less than 1 max, and we can use we can I'll prefer the uterotonics oxytocin as a 5 to 10 international units bolus, followed by the infusion, which is 5 to 10 units per hour. Maximum of 40 international units of oxytocin can be given. Other second choice of uterotonics are carboprost or mesoprost. And regarding the extubation, if the train of 4 ratio is more than 0.9 and the patient is fully awake, I will plan for extubation. And regarding the post-operative analgesia, we have to ensure adequate analgesia and appropriate pain relief should be done. And NSAID should be avoided since it can cause renal dysfunction. And if there is no symptoms of liver dysfunction, we can give paracetamol, and we have to monitor urine output and BP also post-operatively, and magnesium sulfate throughout the therapy 24 hours post-delivery, and we have to send the serum magnesium levels and titrated, watch for eclampsia levels and watch for magnesium toxicity, and we have to prevent pulmonary embolism, and all the gadgets should be kept post-operatively, and we have to prevent measures for postpartum hemorrhage. Thank you, sir.
Very good. It was a very, very detailed presentation. Provided the question has been asked as a 25-year-old primate diagnosed with preeclampsia with a BP of 200 by 120 with headache and blurring of vision. How will you manage it? That is the question. Whatever you have prepared and presented will be the ideal way to answer that question. But here, the question is, she is a 25-year-old primate, 34 weeks of gestation, complaining of headache and visual disturbance with a BP of 210 by 120. How to proceed? So this is a clinical scenario given to you. So this sort of question may come to you in your practical exams, where they may give this scenario and ask you to describe, or this may come in your theory question paper also, in the clinical anesthesia paper, as to what to do that. Now, in your elaborate presentation, you have not mentioned anything about the 34 weeks of gestation at all. Am I right? Whether
Yes,
she
sir.
is now
Yes, sir.
fit to be
Yes, sir.
delivered at this
Yes, sir.
stage or not.
Yes, sir. Yes, sir. I forgot to
You have
mention
not
it.
taken note
Yes,
of
sir.
that, number one.
Yes,
Number
sir.
two, you have made a diagnosis of severe preeclampsia without any investigations to prove that it is eclampsia only, preeclampsia only. So what is the most important finding that the patient should have to brand her as preeclamptic patient? Is a BP of 210 by 120 present only in preeclampsia? Can it not be present in a patient who is a known hypertensive with a phephromocytoma of preoperatively, have a pre-pregnancy?
Yes, sir. Yes, sir.
That is
We
also
all.
possible, isn't it?
Yes, sir. Yes, sir.
So
Marker
your
of severity,
so
serum
what should
uric
have been
acid.
your diagnosis?
Regarding the investigation, sir.
No, you don't have any investigation report in your clinical
Okay, sir.
scenario given.
Okay.
So
Yes, sir.
with the BP and the findings and the description of the case that has been given, what
Yes,
should
sir.
be the ideal diagnosis that should have been given?
Late onset severe preeclampsia, sir.
No, if you want to say preeclampsia, there should be, which particular test should be positive?
Serum uric acid, sir.
Serum uric acid. Anybody else?
Sir,
Anish?
is it protein in the urine?
Proteinuria. Yes, it is
Urine
proteinuria.
dipstick PCR. Urine dipstick. Yes, sir.
Proteinuria, if it is present with a high BP, then only it can be called as preeclampsia.
Yes, sir.
Okay?
Yes, sir.
So
Yes,
without
sir.
knowing whether the patient has proteinuria or not, to brand the patient as preeclampsia will not be accepted in the examination. Okay?
Yes,
So
sir.
your
Yes, sir.
diagnosis should have been hypertension complicating pregnancy.
Yes,
Only
sir.
when you do the investigations and find out whether she has a proteinuria or not, then only you can brand her as a preeclamptic patient, not merely because the BP is very high and she has a headache, she
Yes, sir.
has a visual disturbance, all these things. Okay, that
Yes,
is
sir.
number one.
Okay, sir. Yes, sir.
So there is number two. The first point is you cannot dogmatically say that she is a severe case of preeclampsia without knowing whether her urine has proteinuria or not.
Yes, sir.
Second thing is you cannot ignore that the patient is only 34 weeks of gestation, where the fetus is likely to be premature. And if you deliver that, there is a problem that can happen to the survival of the baby. Okay.
Yes, sir.
So, without jeopardizing the mother's life, if you can prolong the pregnancy for how many weeks to make the child more viable and more stable?
Up to 36 weeks, sir.
36 weeks, very good.
Yes,
So
sir.
if the baby is born at or after 36 weeks, the chances of the baby surviving well without the need for a neonatal intensive care is much higher. So the
Yes, sir.
question, this sort of question is asked in the examination for you to discuss whether it is safe to allow the mother to continue with the pregnancy for another 2 more weeks so that the baby will be more viable. or is it more riskier for the mother's life and you should immediately deliver the baby so that mother's life always takes precedence over the baby's life in this sort of scenarios. Okay? If only the mother
Yes,
is
sir.
alive, she can have one more child, no problem. But in the
Mhm.
your enthusiasm to save the fetus and baby, if you allow the mother to succumb to a complication of preeclampsia or hypertensive complication of pregnancy, then that will be more dangerous, more riskier. Isn't it? So
Yes, sir.
mother's life always gets priority over the fetal life, but you should decide
Yes.
whether you can safely treat the mother and bring her down the severity from very severe to severe or mild and moderate by proper treatment. So you can always give a trial of treatment to control. Here the most important problem is severe hypertensive episode. What are the risks of this high BP? 220, 210 by 120, it is continued for without treatment. What are all the risks that the mother will have?
Mother is at increased risk of intracranial hemorrhage
Fantastic.
and
Okay.
and also at risk of a pulmonary edema and stroke in the
Very good.
future.
Cardiac failure.
Yes, sir. Increased risk of cardiac
So
failure
it
also.
can affect the cardiac system. It can affect the central nervous system. It can affect the respiratory system.
Respiratory system.
Okay. So all the three complications: cardiac failure, acute pulmonary edema, cerebral hemorrhage or stroke, all can happen if this BP is continued to be sustained for this high level. So the first answer for this sort of question scenario is we must admit the patient immediately. If this patient comes to the OPD,
Yes,
she
sir.
must be immediately admitted and kept under observation, and treatment to control the BP should be started immediately. Okay. All the other
Yes.
descriptions of your taking history, your history of examination, antenatal history, whether she has been immunized or whether she has been started on iron and folic acid, all this will come for a examination of a regular pregnant patient if it is given to you as a clinical case without TB or without complications. Okay. But I
Yes.
don't say that you should not describe all these things, but this will the examiner will not give you that much time to feel you all these things. So in this sort of complicated pregnancies, the attention and description should be more towards the problem that is facing or likely to cause a risk to the life of the mother. Okay? So to brand this
Yes.
lady as a case of severe preeclampsia, we should immediately ask her whether she had been diagnosed with any high BP and proteinuria earlier in the antenatal period. That history we can always get from the patient. And if she has been
Yes, sir.
coming for regular checkup from the previous, this is now 34 weeks, right? From her the date of missing her periods, if she has been confirmed to be pregnant, the first question you should ask is, have you been attending the antenatal checkup clinic regularly? Were you diagnosed with a high BP earlier, or this is the first episode of high BP? Have you ever been tested for presence of protein in the urine? So, what is the normal colloquial way you can ask the mother to get the history? How will you ask the patient about whether they had a proteinuria? In Tamil speaking community or people who come to the OPD in hospitals, how will they describe that they have proteinuria? Any idea? Which
Frothy
college did
urine.
you study? Ranjani?
Frothy urine, sir.
Huh?
Frothy urine, sir.
Frothy urine. Cloudy urine, not frothy urine. Maybe cloudy urine if it is a high protein. But usually, in the Tamil speaking patient, they say, உனக்கு யூரின்ல உப்பு இருக்குன்னு கூட சொன்னாங்க. They will say, that is how they will describe. The protein, they say, call it as uppu. Okay? So, I was told that I have the uppu in the urine, which is an indication that we had proteinuria. And if you ask the history whether your urine is little cloudy, then that also may indicate the amount of protein that is lost, which will make the urine not clear but more cloudy. So that will tell you that the patient is suffering from proteinuria, and I mean, she has been diagnosed with that. The next question is, in case you have been diagnosed with IBP, at what stage of your pregnancy it was diagnosed? Why it is important? When will you call, or what is the definition of preeclampsia or pregnancy-induced hypertension for that matter? When should it happen? Should it happen on the day when our pregnancy is diagnosed, or is there a time period after which it will usually happen? Yes, Kumar? One second. Hello? நல்லா இருக்கா? சரி சரி. Sorry. So what is the time period after which usually this hypertension develops in pregnant patients to brand them as a hypertension complicating pregnancy?
20 weeks, sir.
20 weeks. What is the sanctity about 20 weeks? Why do they describe or define that the patient to be called as a pre-eclamptic patient, new onset hypertension after 20 weeks of gestation? That is the definition of pre-eclamptic hypertension. So why they say it is 20 weeks? Any idea? What happens during the first trimester of pregnancy? When a woman becomes pregnant, what are the changes or what are the things that happen in the uterus of the mother who becomes pregnant? Ranjani, are you able to hear me? Hello? Are you able to hear me? Kamachi? Am I audible?
Yes, sir, you're audible, sir.
Ranjani is not answering. Anybody else who can answer that question? What are the changes that happen in a pregnant woman? Dr. Sri, Bindu, are you all there?
Yes, sir. Yes, sir. We are there.
Ah.
In the first trimester, the organogenesis process is completed, and in the physiological changes which are occurring. So, if we have to go one by one through the systems, like first in the cardiovascular system, there
No,
will
no,
be.
no. I'm not asking about the changes that are happening in the other system. What happens in the uterus? See, the female ovum gets fertilized with the male sperm and the zygote is formed. Okay. So where will the zygote go and get itself lodged?
In the
endometrium of the uterus, isn't it?
Yes.
Okay. So how does it get implanted there? By formation of placenta. Isn't it?
Yes.
Placenta is the communication between the fetus and the mother. Okay.
Yes.
So how does the placenta get its blood supply?
Trophoblast and syncytial trophoblast formation, and the
which blood vessels supply blood to the placenta?
Spiral artery also.
Spiral arteries, that is the answer. Spiral arteries, which are branches of uterine artery, which are all along been supplying the endometrium of the mother, of the lady. They only grow and invade into the placental tissue and supply the blood to them. So what important change happens in the spiral artery of the maternal system before pregnancy and after the formation of placenta? Before the lady becomes pregnant, what is the nature or histology of the spiral artery, and what is the nature of the spiral artery after the placenta is formed?
Resistance is more before pregnancy.
The muscular force of when you say an artery has got a thicker muscular cord than a venous system, isn't it? Wherever in the body, veins have lesser muscle and more dilatable, which are called capacitance vessels. Whereas arteries have a contractile property and they are more resistance vessels. So in a non-pregnant woman, it is a resistant artery which can control its blood supply by contracting and dilating. On the contrary, once it becomes a placental artery, the invasion of trophoblasts, they eat away all the muscular core and convert this resistance artery into capacitance artery, so that the placenta is bathed in a pool of blood. It doesn't have that property of pulsatile flow like your other parts of the body. That is why the placenta has got almost a syncytial arrangement, just like your cardiac musculature. And it doesn't have an auto-regulation because there is no muscle coat in the arteries, like the spiral arteries, which are supplying the blood. Okay, so it is just like, if you want to compare it to the hepatic lobule, where the blood is in the disease space and the blood supply there is also bathing the hepatocytes. Similar to that, the placental tissues are also bathed in blood, through which the transmission of gases and nutrients can happen between the mother and the fetus. And this process is complete only by 20th week of pregnancy. Even though, as she rightly said, the organogenesis and other things are all completed during the first trimester, 12 weeks of pregnancy. Further growth only happens after that, but the completion of the implantation of the placenta and all the changes that take place in the spiral arteries happen only up to, they continue to happen up to 20 weeks of pregnancy. So any blood pressure rise that happens after 20 weeks is called a hypertension complicating the pregnancy. That can be, what is the classification of hypertensive disorders of pregnancy? How do you classify that?
Hypertension disorders of pregnancy classified as preeclampsia and eclampsia, which is preeclampsia's onset after 20 weeks plus proteinuria, and PIH, also known as gestational hypertension. Gestational hypertension is onset after 20 weeks without proteinuria, and chronic hypertension, which is onset before 20 weeks or before pregnancy. Other one is chronic hypertension with superimposed preeclampsia, which is onset before 20 weeks plus proteinuria.
So these are the 4 categories of hypertension. So when the question is given that a lady with 34 weeks of gestation with a BP of 220/120 without the evidence of proteinuria in the urine, we cannot categorically say that she is suffering from severe preeclampsia. Okay? So we have to see whether the investigations have been done and whether proteinuria has been proved in this patient to say whether that patient is suffering from that. Okay? So that is the most important thing that we have to make in the exam. So better safe to give a diagnosis as hypertension complicating pregnancy. See, with a patient having a fetus which is still in a premature stage. If delivered, baby will be definitely premature. So our problems here have to be whether to continue with the pregnancy to at least 36 weeks so that the fetus will be more viable, and at the same time whether we can safeguard the mother by treating her hypertension without. What is the most important risk of preeclampsia other than the cerebral hemorrhage of BP and all that? What important complication of preeclampsia we want to
Eclampsia,
avoid?
sir. Seizures.
Huh?
Eclampsia. Eclampsia is the
Eclampsia.
complex.
Eclampsia means patient throwing a fit. Okay? So we want to avoid that. We want any patient diagnosed with preeclampsia, we want to avoid any eclamptic fit occurring in the patient. That is the most important goal of us. So that is why we try to treat the hypertension. We try to give prophylactic treatment for preventing the hypertension in the form of magnesium sulfate infusion, if necessary, other epileptic drugs also, depending upon the severity. Okay? So if supposing patient had a fit, how will you treat that fit? Any epileptic patient, what are the steps in the treatment of that epileptic fit?
We have to administer high flow oxygen, sir,
Very good.
initially, and we have to turn the patient to the left or right lateral decubitus position, and
Very
we
good.
have to introduce a bite block, and stand rails is must for the patient, and we have to suction and clear the since aspiration is most common, and
Very good.
we can proceed with further induction if the patient is proceeding for delivery.
Very good. So these are all the usual common steps in the treatment of any epileptic patient. Oxygen supplementation, lateral position to prevent aspiration and removal of secretions, and anti-epileptic treatment to control the fit. Okay? That is the common steps that we have to follow.